Welcome, everybody. It is May 23rd. It's Friday. And we're very, very excited today to have a group of folks who did some amazing work just last week in Kentucky, London, Kentucky, to be exact, which is near Lexington. They had a significant EF4 tornado come through in the middle of the night. And I happened to be at FAST 25, which is the For Life Bridge Ed conference. And I was having dinner with the chief from Lexington, Kentucky. And he was telling me, he said, you wouldn't believe, Doc, they had this one little hospital had 100 patients. And I said, there's no way that one hospital took care of 100 patients. He says, yeah, I can tell you the doctor's name that I know who is there, but you probably don't know him. And he said, Will Cross. And that's the guy all the way to the right of the screen. And I said, I've known Will for many years. So I texted Will and I said, and Will was honest. He's like, I wasn't really the guy doing much, but I'll put you in touch with the people who did. And that's how this whole thing started. So I'm really meeting for the first time all the folks, Jason and Cliff and Lori. Is Nick on, trauma surgeon? So he's the one, the fourth from the left, the trauma surgeon. So if he comes on, that'll be great.
I think he
But
said he had surgery, or he said it may be tight, but thought he would be on.
okay, well, if he comes on, we would love to hear from him as well. So I'm going to stop the share, and what I'd like to do is I'm going to start with Jason, Dr. Jason Deskins. Jason, if you can just go and first of all introduce everyone who's here that was on your team from the hospital that day. I see Lori sharing her screen, so either one of you can do that. Thank you both so much, or all of you so much. We have a lot of people on this call who have been through many MCIs. Dr. Pepe wrote a book on this stuff, and we're just so impressed by what we heard you did. We can't wait to hear what you did. So take it away. Appreciate you guys coming on.
I'll start and then you take off, Doc.
Okay.
So this picture right there on our opening is actually a terrifying picture that Will actually sent me. This is the tornado that hit us. It was unreal. Excuse me. To give you a little bit background about our hospital, St. Joseph, London, we are a 150 bed hospital. We serve about 7 counties. It's a 38 bed ER. We see between 36 and 37,000 patients a year. Our ER staffing model, we have RNs and paramedics. All of our paramedics are critically care endorsed and operate at their full scope. We are operating as a level 3 trauma center with our actual ACS survey coming up in January of 26. I put the PIT model, the provider and triage, on here because that was instrumental in this getting patients seen. So on Friday night, about 23:43, an EF4 tornado touched down in London, just south of the city limits, with a potential for a second tornado in the area. So it was after the first one hit, it was
I know.
unsafe for a lot of people to get out and get to the facility to be able to help. Initial reports started coming in with multiple casualties and many deaths. The hospital, we established incident command. We were lucky that the actual facility sustained no structural damage or utility issues. So in the 24-hour period, we saw 108 victims from the tornado, but our daily census that day was 147, including all of the usual patients that present. At the height of the event, we had 83 patients from the tornado that were at the facility. We ended up transferring 11 of those. 10 of those we admitted. Some of those went straight to the OR. We did have one death at the facility, but there were 17 outside with EMS. One thing that we did have 3 elope that came in and decided they they saw the mess and they left. But one important note, we had 0 leave before they saw a provider.
Wow.
What went well was our market leadership provider caregiver response. We had everybody that could and did called us and came, and the community partners, we have 2 hospitals that are probably within 30 minutes. One of them sent 21 people, 4 providers and 17 nursing staff. Another one sent a provider who was there probably 20 minutes, and then they rolled his mom in.
Mm.
So she was critical. So he was actually very happy not happy that it happened, but happy that he was able to be there for her. We had to open a 3rd ER over in another side of the building. We called it ER3. That was where we moved our minor injuries to after their initial triage. The overall response was just amazing. Things you talk about in all of your incident command classes, we used them. We had we had to set up a place. We had people that showed up that were just seeking shelter. We had to find a place for them. We had to find a place for the media. People even showed up with their pets. And, I thought that was interesting because you talk about that in incident command that in all your classes and your training that you got to plan for that. And we actually use that. One of our local aeromedical services sent 4 staff members. One of those was instrumental in transporting. As I said, we transferred 11 out to higher level of care, and the pre-hospital providers, all of EMS, they were all tied up on scene. So transportation was an issue trying to get those patients to Lexington. So that air evac stationed one of their people right with me all night. So if Dr. Deskins would come and say 22 needs to go to Lexington, I would tell him, he would notify the outside command center. We'd have a truck there to transport in 15, 20 minutes. It was impressive. Anything you want to add to that, Dr. Deskins?
Yeah. So just to kind of give you an idea, I think she said 12:30 something at night. So by that time, usually in the ER, we have me as the provider and 2 APPs. One of the APPs leaves at 1. So it was almost 2 of us there. I can't remember I think the APP ended up staying, didn't they, Lori?
Yeah, he stayed.
So there's 3 of us there, and I'm from Eastern Kentucky, so tornadoes isn't really an incident, and I don't know if most people are just thinking, this may not be a thing or whatever. But all of a sudden, I started getting chatter from the nurses, and also hearing EMS calling in, and then suddenly, in a very short amount of time, there was 15 traumas showing up on my board. So I ended up calling down the general surgeon, and then luckily enough, we had orthopedic surgery on call because I knew that they were calling in for amputations, partial amputations. So in the beginning, it was 2 APPs, me, a general surgeon, and an orthopedic surgeon who just started going at it. They were rolling them in. The nurses were really instrumental in, kind of calling, this patient needs to go to trauma bay. This patient's going to 22. This patient's going to this room. And it's almost kind of like what you see in a movie or a TV show. You're just running from room to room, just seeing if they're talking or breathing. You're quickly trauma assessment oriented, getting that done. You're we were putting in chest tubes just urgently. We were intubating patients, and we were just trying to stabilize as many as we could. We had multiple people that had penetrating abdominal wounds that the surgeon and I were working with. We had tourniquets on that me and the orthopedic surgeon was, checking stability of the arm and, taking the tourniquets off, seeing what the viability was. And we did that for hours. And eventually we started out, we were worried about not having enough EMS crew to get, because we were getting to the point where there were so many coming in and there were so many critical patients that we needed to have other places and facilities for them to go to. So I saw somebody send a message about, do we have command centers? We do. So eventually we had so much support from EMS and from flight crews that, they were just sitting there saying, listen, I've got 9 trucks sitting here waiting for you. Just give me the go and we will get them moving. And it just just, it just seemed to flow all night. I mean, nobody just stood there in a stare. Nobody freaked out. I mean, the nursing staff, all the staff, everybody there were just doing exactly what we do in like Lori had mentioned in the mock trauma trial, the mock trauma casualty situations and mass trauma events. It went great,
So,
and I
so
can't
Jay,
go
so,
ahead.
so there's so much to unpack, and I know that there's people on this call itching to ask some questions, but I want to kind of back up a little bit and just take us through when you heard this thing had just happened. What were the initial steps that you took? You, Lori, Cliff. I know Will's on the call too. As far as like your preparation for, hey, we're about to get a whole bunch of casualties. Take us through those first couple of steps, and if you could look back on what worked and what didn't work.
Sure. Well, we have administrator on call, so anytime I need to reach out for our group, we have somebody available that I can get a hold of. And as soon as I started hearing all the chatter and seeing these people lining up, I knew we were very understaffed from a provider standpoint. So I got a hold of our AOC, and he quickly had sent out mass messages and had initiated the protocol to get people to get to the hospital, because that was my main concern, was having so much trauma. There's only so much at that point, even with a general surgeon, or orthopedic surgeon, and me and 1 or 2 providers that we can handle. So we ended up, whenever people was able to get in, we had a couple more providers that were able to show up. 2 actually were able to show up, Dr. Crawford and Dr. Proudfoot. And I felt like that was somewhat instrumental in getting enough people mobilized. We didn't realize how many people were coming in. It was just an unknown factor at that point. And then I know that the nursing staff and Lori and everybody was mobilizing um, EMS crews and flight crews. And then also, because of trauma, not everybody has mass trauma, but there were so many patients that came in for, deep lacerations, multiple wounds. So we had multiple APPs that were coming in just to literally stitch patients up.
Okay, and now as far as the crowd is coming in, and the other question I had for you all is, where did you kind of set up triage? Did you put it outside the doors of the hospital, or were people just kind of like bleeding, trying to come in, pushing their way through? How did you manage crowd control when you had 100 people show up at your door?
We actually had triage. It was right in front of the ED. We had 3 rooms set up for triage. All patients, when they presented, security was at the door, directed them to one of the triage areas. They were triaged, and then they were either designated to go to the main ED, ED2, or the ED3 that we set up.
Gotcha.
And
Okay.
the trauma patients that were on the call that we knew were critical were automatically being sent to the trauma rooms.
Can you give us a breakdown of the, kind of now in retrospect, of how many, let's just call them red, yellow, green type of patients? Like, the how many really critical patients did you have that you were tubing, chest tube, central line, all those, like what percentage of the 100 did that encompass, out of curiosity?
I don't know if I have the data, but I know we put chest tubes in. Sorry, there's a call. I can't get off there. I know we put chest tubes in multiple patients, three or more. I know we intubated more than 5 or 6 patients within a very short amount of time. I
Okay.
don't have the exact data on that. That would be something I'm sure Dr. Cross may have.
And then there's two other questions, and I want to get Cliff in here too from the EMS side. But how did you utilize your paramedics? Were they incorporated into the emergency department? That's one question. And then the other question that's related to the in ED care is the blood. Do you guys have whole blood? Do you have component therapy? Did you have to give blood? And I'm just curious as to see as to what percentage of those patients actually needed a transfusion.
We did give blood, and I know at one point I think we had 1 unit left. So I don't know. Lori would probably be able to tell you how much blood we had initially, but I know that at the very end we only had 1 unit left, as far as I was aware.
We actually stock 12 units of oneg in the blood bank on a normal day. We did at one point get down to 1 unit, but the lab blood bank staff actually called and we never got any lower than that because they were able to get more in, and we were within an hour, we were back up to 12 units. So we gave lots of oneg.
Wow. All right, and so Cliff, if you wouldn't mind introducing yourself and then letting us know from the EMS perspective what was happening while this whole thing was going on.
Yeah, I'm Cliff Freeman. I'm the medical director of the ER at London, and I'm the market medical director of EMS. So I'll talk mostly about EMS with the caveat of Lori and Jason and plenty of other people were doing the work there, and I was not one of them. I got there later that morning. But from an EMS standpoint, so all of our disaster responses in Kentucky are run by the Kentucky Board of EMS, K-beams, as I will call them. I think we really do a good job of disaster responses. This is my second MCI in Kentucky, both of them being tornadoes. But the K beams alert went out at 29 minutes after midnight. So to be able to be licensed in Kentucky, every time you come up for your EMS relicensure, you have to participate in a mass casualty drill with other EMS agencies. And then to be an EMS agency in Kentucky, we require everyone to have backup radios that communicate with each other. So one frequency. So I think that's fairly helpful. But the way we do it is we call in strike teams. So each strike team has 5 ambulances. In this case, we had 3 strike teams. One was sent to Pulaski County, which was also hit. It is the neighboring county to Laurel County where we were. We sent 2 strike teams to Laurel County. Again, each one with 5 ambulances. And our rule for strike teams is you can't be contiguous to the affected counties. So we're really trying to get fresh crews that aren't affected by whatever the disaster is. So we got 10 ambulances initially to Laurel County, 5 to Pulaski. We ended up moving the 5 from Pulaski to Laurel County. I've got a list of 5 here. This is because I was trained by Corey Slovis. So next time, Peter, Paul, you guys see Slovis, make sure he knows that I have my list of 5 in here. But the response phases, I had initial emergency calls. Those were obviously handled by our local organization. There's a private EMS agency that does 911 in Laurel County. Then the mutual aid, those strike teams, the 3 total strike teams. And what I thought we did really nice here was this staging, because we're about, if you're driving fast, an hour and 20 minutes from the level 1 trauma center. Again, we are trying to become a level 3 trauma center, but it was clear we were going to need to get some patients up to the University of Kentucky. So they did a really nice job of staging out ambulances with the thought that we can't put everyone on 911 calls because we're going to need to get the transfers out. We sent a communications liaison to the hospital who sat right next to Lori and decided who needed to go out. So ALS, BLS, vented or not were the questions. And as soon as we had those questions answered, we could get the patient out. Lori is also a paramedic. I don't think she mentioned that. So very helpful for her to have that background for us. And then we worked on getting the transfers up to UK, which is where most of our transfers went. Some went to our sister hospital in Lexington. Essentially, we have trauma surgery, but we don't have the more complex surgeons. So hand surgery, facial surgery, vascular, things like that needed to go to a larger center. And you can click on that next slide now, Lori. So I do think what was interesting from a triage perspective is we had multiple areas of triage, which we always do. Obviously, they had the scene triage, but then really the first casualty collection point was our ED triage, where they decided if they were going to ER 1, 2, or 3. We were lucky enough to still have that advanced provider left over from the mid shift who ended up staying late, who was out there. So between him, nurses, and our paramedics were able to triage those to either go to triage 1, which is, or ER1, which would be red, ER2, maybe a little more orange, and then ER3 was essentially all the people that needed laceration repairs, but it kind of kept them from clogging up the main ED. Then we have our ED docs see all the reds, and they decide who needs the surgeon. We only had one surgeon at the time because some people were out of town. So Dr. Deskins was able to say, hey, this person needs ortho, this person needs trauma surgery. And then the trauma surgeon's doing his own triage because he had to decide who needed to go to the OR right now versus who is stable enough that they probably still need technically emergency surgery, but can they be stable enough to get up the road to UK because we only have one trauma surgeon. He couldn't operate on everyone. So off the top of my head, we had 3 emergent amputations that just had to go to the OR right away. And then some other like open fractures we could defer out and get to another trauma center to take the load off of our docs. And then obviously the 5th triage was at the level 1 trauma center when we were able to transfer those patients. One more side note is we do have paramedics in our ED. Lori mentioned that, but we have all critical care paramedics and they're all able to practice with their full scope of practice. So plenty of EDs have paramedics that essentially practice as ER techs, but our paramedics are able to do everything their license allows them to do. So giving blood, giving medications, ultimately they didn't need to that night, but if you need extra hands for a chest tube or an intubation, they're able to help with that as well.
So I think that's a fantastic, very important point. If anyone's on here from the hospital, after COVID, many of our paramedics were kind of swooped away once the hospitals realized how capable paramedics are, right? It's like an aha moment. But to hear what you're saying, that not only were you having paramedics, but they're critical care medics. And if, the shit was really hitting the fan, you could have those paramedics just start to handle individual cases on their own. How nice is that? So that's just another very valuable piece of information that I think a lot of hospital administrators have recognized. But when did you make that policy, or for how long had you had critical care paramedics working in your emergency department?
It has been just over 2 years now, so we're very used to it. So a regular ED day for us has plenty of critical care paramedics practicing at their full scope. It is not strange for them to do a chest tube or an intubation. So this was not an overnight thing, but we've been doing it for a few years. So everyone's pretty comfortable with it now.
Wow. Wow, that's fantastic. I'd love to hear more about that. Okay, well, I know we're getting close. We're probably going to run over a little bit, but before Dr. Pepe goes to his webinar, Paul, we'd love to, let me get everybody off the spotlight here so we can get everybody else in here. Dr. Pepe, can you make some comments? I know you've written books on this stuff. You've written chapters on this stuff. Love to hear your comments on the
Yeah,
great work
and
you're
and I
taking folks
took the
in.
garbage out today too. So no, but the interesting thing is people are generally killed outright, and only about a few percentage of patients sometimes are the ones that are critical. And they also had a lot of cases that needed immediate here, but that means it's a wide scope of patients they saw. What happens a lot is that, and I'm curious to know what happened here, is that patients are often driven in from a scene because they can't reach ambulances or whatever. They just leave. So I was wondering, one of the things we learn in various places, such as Las Vegas and so on, when we had lots of people, is that we really had to have a pre-plan for setting up triage outside the hospitals because people would just show up in those areas. And I was wondering if you did something along those lines and what the weather was like, because that also affects the ability to do that. Sometimes people set up tents or whatever, that kind of thing. So, did you do anything along those lines, or do you think that would be valuable for you in the future?
I think in the future it might be. We did not have to do that in this case. We actually have a very large ED lobby. So when patients presented to the ED entrance, the police were bringing them, staff were bringing them. Uh, they were coming POV. I mean, they were arriving by all different methods.
Well, that was my point, I think. Yeah, but go ahead. Yes. Okay.
Yes, absolutely. But they would present, they would actually get into the ED lobby, and we actually did triage in the lobby
Okay. There you go.
before we
Yeah.
went to
Yeah.
triage, but not outside the building.
Yeah, okay. Maybe I should have been more precise about that, but yeah, outside the emergency department, it would be
Yeah.
a good way of putting it. It's interesting, by the way, just as a little, this is more of a sidebar, and it could even affect large apparatus in these things. But when you have tornadoes go through, they leave a lot of broken glass and debris, and we see people not making it to scenes or responding, even ambulances, because they're getting their tires flattened out by all the broken debris. So something that has to be kept in mind and part of the public safety plan as well as for response.
Absolutely, and I think they learned that the hard way.
Oh, they did. So here we go. There it is. There it is. So,
All
okay.
right. Excellent. Thank you, Dr. Pepe. Let me bring
Okay.
in my co-host Tanner Smeda. Tanner, first of all, congrats on your recent wedding. But you're back and you're locked in here. What are your thoughts here on the conversation?
Yeah, so I'll say that when it comes to the published data that's out there around disaster response and EMS, I mean, the data is really sparse. This is a really hard thing to study because of the rarity, and then also related to things like documentation challenges in the moment. And so one question I had for you, and I have a few other comments, is, when you have all of these patients coming in, were you able to rely on kind of the standard Epic or electronic health record that you used, or did you resort to some other form of documentation during triage? When you're intubating, 5 or 6 people at a time and putting in all these chest tubes in the first minutes of this disaster, how did you document this care? And I would also like to say, I think that the literature would certainly benefit from a description of this emergency, the response, the acuity of these patients. So I think that's something that I would certainly like to read, and I think could benefit the EMS community as well. For my second question, so you know, in terms of decision making that falls on EMS clinicians in the setting of trauma, the most important decision that's made is often destination, right? And field triage of a lot of these patients. I understand that the calculus here kind of changes in the setting of a mass casualty event and in the setting of some of these disaster responses. But I wanted to ask the group, do you think that some of the burden on your hospital could have been lessened by triaging some of these critically ill patients to level 1 trauma centers? Was this prevented by weather? Were routes closed? I'm assuming air transportation by helicopter might have been prevented by weather. Was there any perhaps role of increased efficiency of field triage in making destination decisions and lessening the burden on your hospital system?
Our
Cliff, you can take that one. Yeah.
So on the helicopters, we have 3 helicopters in town, but the airport got hit by the tornado, so all the aircraft were out of the equation. 2 of them were permanently damaged, so helicopters were out of the question. Essentially, our level 1 trauma center was just too far away. If you're fast, it's an hour and a half, which takes your ambulance out of the equation for 3 hours. It just wasn't an option. I think if we had been a little closer to Lexington, maybe, but in this scenario, it was just everyone had to come to us.
Great. And how about that first question, Jason or Laura, you want to take that one? Documentation, do you just kind of fix people and then document it later?
That
Yeah.
was a lot of it. Yeah, absolutely. We
Good
do.
old pen and paper. I would just write the room down
Yeah.
and quickly put a last name or just put intubated, and then and put a little blurb down, because there's no way you can go to Epic and do that kind of stuff.
Right. Now, the other question I had, which again, this didn't happen, thank God, but I was talking yesterday to Dr. Jim Augustine, and he was telling me about some tornadoes that were coming towards his area many years ago, and that it literally was coming towards the hospital, and it skipped over the hospital. Thankfully, your hospital didn't get impacted, but it just kind of little even more harrowing to think what would have happened if the hospital would have lost power. Do you all have contingency plans on what to do if that's the case, if the hospital that's an hour and 20 minutes away from the trauma center gets impacted?
Yes, we do. We actually have two generators that both will support the whole hospital, so we have a redundancy there for power. Structurally, it would depend, of course, on how severely it was impacted. We have alternate care sites that we have established that if the ER is impacted or the facility, we would relocate the actual ER and patient care.
Wow. Wow. You guys have thought of it all. Okay. That's great to hear. I want to bring in, I know that you have other members of your team. So I know Will is here. I see Dr. Stenko is here. I would invite either of you to unmute and make some comments on the wonderful job your team did here, because it's just really incredible to hear what we're hearing here today.
Thank
This
you
is
so
Will.
much. Go ahead, Will.
Shelley. No,
I
after
was just
you,
going to say
please.
we are incredibly proud of our team. I am driving today, so I apologize for not being on camera. I want to highlight some additional staff, so CRNAs who came down and helped with the intubations, critical care who also came in to help with chest tubes, and so the response was fantastic. Definitely something that we will continue to unpack and learn from, but hope we never experience again. But I just really can't express. This is my hometown and my neighborhood that was impacted. So this team was fantastic and just meant everything to our community.
Wow. Well, we hope that all of your families are doing well. We don't really experience tornadoes. I mean, lately we have had a few, but nothing to this extreme. And so thank you so much for that commentary. Will, go ahead.
Yeah. So thanks, Peter. I actually am having some technical issues too, so you don't get to see my pretty face and bald head today. But just look at Cliff. I'm the prettier version of him, and you'll see it. So let me just say, I was saddened by the fact that I didn't find out about this until a little late. One of the things that we did recognize through this is that communications were hit in such a way that we have the typical code yellow from the hospital that comes out, and what we realized is that some of the people in London got the code yellow, but those of us that lived outside of London proper never got notifications through the conventional channels. Fortunately, Dr. Deskins ended up calling. We have an administrator on call for the emergency medicine program, where one of the four of us, Cliff, myself, Hartej Dillon, and Mark Sloan, will take call and ultimately are responsible for mobilizing our teams and kind of going in to help out when those things occur. So fortunately that happened, but it was a little later that we actually realized how significant this event was. I think we got the history that Somerset, which is a little further south from us, had a tornado touchdown, didn't really recognize that it was actually in London proper that was hit. There is a hospital in Somerset, and that's why that's relevant. We figured that they would have gotten the bulk of those patients, at least conventionally. But once we realized it was us in our area, we quickly mobilize as many people as we could. And to Dr. Stanko's point, it was absolutely remarkable the amount of people that showed up. I mean, one of the docs that showed up was somebody who we had let go about a year ago, and for various reasons, and he just lived in the community and said, "Hey, I'm here." And we said, "Hey, love seeing you here. Please come back in, help us." We had a hospital, I don't know, what is it, Shelley, 20 miles up the road, Corbin, that had sent 21 RNs and 3 APPs. And really, Cliff mentioned that they did that suture clinic is how I'm calling it, in ER3. I mean, there were a exorbitant number of patients with lacerations that these 5 APPs spent nothing but hours sewing just to try and take care of. And so I was absolutely blown away by the response that we got from the community. I think it could have been much worse than what it was had we not had that help. And, back to your point about Cliff's point about the paramedics, one of the things, you know me, man, I'm a medic. I've been a medic. I continue to keep my national registry. Right, Cliff? I'm a real paramedic. You're EMS fellowship trained, but whole different story there. We won't go down that path. But nonetheless, we have really worked pretty aggressively at trying to build relationships with our local EMS and then our paramedics in the department. And so I would just say our team absolutely killed it. I was so proud of them. I continue to be so proud of them. We had nurses, techs, paramedics, housekeepers. At one point, I saw the director of dietary, and I said, "Hey, dude, we need some energy drinks down here." He came back with a cart just full of energy drinks. I mean, stupid stuff, but this is 2025, right? So everybody has to have energy drinks. It was awesome. I mean, I'm really proud of our team.
Wow.
Peter,
Yeah.
can I point out too that
Yeah.
all of this started right at midnight. By Saturday morning at shift change, we were back in normal operations.
Wow. Wow. So you had basically had all those folks transferred out
Yes.
to UK, and you were back to wow. Wow, that's pretty incredible stuff. We have a lot of people on this call who I'm sure have questions, and I would love to hear from some of them. So, David Long, I know you have a lot of experience with this. Maybe even Joseph Zalkin. Anybody on the call who wants to make a comment, ask a question? Would love to hear your voices and just to let these folks know how you feel. Go ahead, Joseph Zalkin. Thanks for commenting.
Thank you, Peter. I think a lot of this comes down to practice and meeting people, networking before the event occurs, so you have a current contact number. I think they were very lucky compared to what we had happen in Western North Carolina. The communication systems remained up in a means of communication. That's critical.
That's actually a very important piece of information. So just to clarify for everybody, you're saying that in North Carolina, because they lost the communications, then things kind of went sideways. Is that what you're saying?
Yeah, I mean, everything from local 911 systems were down, and amazingly, they have a computer system that can relocate inbound 911 calls to the eastern part of the state. So they had a system set up to relay calls coming in from the public that did have communication, but it really, your emergency management folks, both at the hospital and in the community, need to consider a tabletop exercise of what ifs. What if power's out? What if water's out? What if communications is out? What's our fallback?
We had spoken on the Eagles about having Starlink, and I have Starlink in my office just in case here, and I know some hospitals and my fire departments now have it. I wonder if that should be something else people should consider. David Long, come on in, Virginia, Thames.
Hey Doc, just real quick. I think one of the things that we've done in our MCI planning is understanding that really when we talk about these types of events, there are 3 critical stakeholders. There's the 911 EMS, there's the healthcare systems or healthcare facilities themselves, but sometimes we'll leave private or commercial EMS out of the conversation. So in our planning, we actually have when we declare most mass casualty events, our private ambulances are already moving to the hospitals. They're there for, essentially decompression. They're there for, doing those transfers. And it just minimizes that time element of having to make requests to get them moving early, in that process. So going through those conversations early, making sure that the plan's clearly defined as far as who goes where, and then transfer centers are becoming a key component to load balancing, because a lot of times, in this case, you had 100 patients present at one facility. How do we load balance, and try to get people, kind of back to what their normal daily census is. So any work that you can do, with your transfer centers, in kind of choreographing your steps are only going to enhance, your response. But sounds like this was a phenomenal response by everybody at this facility. So congratulations to y'all.
Yeah,
Sure
one of my biggest things that I started to worry about was you've got one trauma surgeon, you've got one general surgeon. We're going through with mass trauma patients. I started to have conversations with them about, okay, I've already got 3 amputations that this one orthopedic surgeon's taking. I've already got a penetrating abdominal wound, 2 flail chest, and they can only take so many. So then that's when we started getting the transfers initiated. I don't think we ever kind of talked about that. About it wasn't necessarily about capacity of the hospital, but it was capacity of what I knew the doctors there could handle, and that was fairly early on during and probably the first hour and a half of the event, was trying to figure out, okay, what can stay, what can't, and when to kind of pull that trigger to start sending them to level 1, because they are so far away.
Right. Wow. Tanner, I know that you had stopped after the second question, but you probably had some more, no? Any more additional comments, or you got them all out?
So one other thing, and this is less related to EMS, but one of the things that's mentioned, I think, a lot in the disaster medicine sections of textbooks and things like that, is that specifically with respect to tornadoes, you sometimes have problems with polymicrobial infections because of blown debris and contamination of wounds, and sometimes delayed closure of these wounds is recommended, perhaps different antibiotic regimens. So I'm wondering, was there any specific differences in the management of these patients that was undertaken in comparison to the average patient who comes into the ED with a laceration, specifically because they have laceration from blown debris from these tornadoes?
I can't say that we necessarily did. I think, to be honest with you, there were so many coming in within such a short amount of time. It was just trying to get people where they needed to be, and we were obviously using ANSEF and certain agents for some amputations and large open wounds and open fractures and all that. But it's a good question. It's something that I need to write down and think about.
So that was taken into consideration with the hospitalist team and the critical care intensivists as they admitted patients. That was part of the conversations that we had around the treatment planning for those that we were bringing in.
Excellent.
There you go.
All right. Well, what I'd like to do now, just as we end, is I would like to invite each of our guests to provide some final reflections and takeaways. So what I would ask you is that if you look back at this event, which happened just a week ago, is there like maybe one decision or action that you think made the biggest impact on the response? And then is there one thing that you would approach differently next time? So let's start, Lori, with you. We'll go to Jason, Cliff, and then if anybody else from the team, Shelley or Will, want to add in after that.
I would have to say the biggest positive, or the thing that went the best, was the whole transfer. When they stationed one of the transport officers at the hospital with me, and we were able to expedite the patients to transfer out, that was instrumental in making this work as well as it did. And I think probably the thing that we learned is you have to provide the staff report support after the event. We are used to the old analogy, the old critical incident stress debriefings, and that looks a little different these days. And we had a trauma patient come in Thursday that was indirectly from the tornado. He had took his own life in relation to what things he had seen. And I think that was just the straw that broke the camel's back for a lot of the ED staff. There were 4 in my office in tears after that. So we identified pretty quickly that we needed to do something. So we had counselors come in who did some group sessions and are doing individual sessions as needed. So I think that we probably should have jumped on that a little faster, but with everything going on, it was just delayed. But we did start that.
I'm so glad you brought that up. Such an important topic. And again, I can't imagine how difficult that was on your team, days later to see that. So our sincerest condolences. Dr. Deskins.
I would say probably, hope I can remember the questions correctly. The best decision was probably recognizing how much help I didn't know how much help I was going to need. I think honestly at first it was, there may be 10 or 15 people show up, but then as soon as I saw 15 show up on the board, just quickly reaching out, realizing how much help I'm going to really need, or the unknown amount of help that I'm going to need. I think I did that literally within, I can't even say it was 20 minutes of the whole thing starting. What was the second one again? I know the
Anything,
best.
is there anything that you would change or that you would do differently the next time?
I'm sure there are, but at the moment, I can't think of anything that I would have.
Yeah,
I just felt like it went so well that
yeah, it
if the
did.
same situation happened again, I would hope it would happen that way again.
Yeah, I mean, you guys did just. I mean, it is fantastic what you did. And let's go to Cliff.
Yeah, again, this is from the outside looking in. I just want to say one more time, Lori, Dr. Deskins did an amazing job. They were the ones there along with some others, but they just did an awesome job. I think most things went well. Lori mentioned EMS. I think a really nice thing was Lexington Clinic staffs, the providers, CHI obviously staffs, nursing, and all the other support being there the next morning. I think the immediate recovery was really nice. We were able to get a lot of providers, a lot of staff in. So we were able, like people who had worked 20-hour shifts were able to be off for a few days, go home and rest a little bit. Dr. Deskins refused. He still worked his night shift the next night. But if they wanted to, they were able to get some rest. And I think things to do better. It's already been brought up, but I think we got lucky with our mass warning calls not going out to most people. It worked out and nothing bad happened, but I think we got to work on that. So next time everyone's able to get the call.
Great. And let's go to Shelley. Any final comments?
I would echo what Cliff just said. For me, the opportunity was we ended up manually calling in additional providers, and that worked. It did work, and we got the right people and the right manpower, but that communication specifically for our physicians and APPs is something that we're working on, making certainly fine-tuned for the next time. As far as what went well, I don't think I have anything to add. I mean, there were a lot of things that went really well, and we're very grateful.
Excellent. Well, that's a great way to end it. Again, we're so grateful that we're able to get you all in here just a week after it happened. Many of us who are in this business, we prepare a lot, but then it's important for us to hear how things go when they really happen in real life.
Hey,
Many
Peter.
of us, yeah. Oh, Gabe, yeah, go ahead.
No, this is actually Will. I'm on
Oh,
Gabe's
Will.
phone
Yeah,
because my stupid
I was
phone
looking
isn't
for you.
working.
Yeah,
I know. Well,
I
just wanted to make a comment.
Yeah, go ahead.
Joe Zalkin, I think, said, I think that's who said about having the relationships ahead of time and making sure that that's where a lot of this work is done. And I will tell you that I think is one of the strongest elements of what we have. You heard from Lori and Shelley Stanko, who both live in the community. They're well connected. They are parts of the community. And I think Dr. Freeman has done a spectacular job with Austin, our director of paramedicine, at developing these relationships. Lori's had lifelong relationships. I mean, she's been a paramedic since 1912. So, you know, it's always very helpful. But I think, you know, the relationship piece was huge. One of the other things that I'd say with the communications, you know, that is hands down the biggest area where we can impact some change. And one of the things we talked about was going back to the old call trees, right? The things that happened back in the day when we didn't even have cell phones, where we would have a list of people we'd physically call. And I think we recognize that that is something that we probably need to have readily available, because we don't. It's not something we did. We rely so heavily on mass communication, texting, that I think a simple phone call would have probably mobilized a lot more people sooner. So that's the other big piece. But hey, thanks for doing this, man. I'm glad that our team was able to share some of the things that they did. I'm so proud of them.
Yeah, and I think that if I would make a recommendation, it would be nice if you all shared this message, because there's a lot of communities out there like yours who are at risk, right? There's a lot of disasters happening nowadays. We saw what happened in North Carolina. They seem to be happening more and more. So the preparedness, and then just having this after action review of what went well, what didn't go well, you know, something that's very important. And I'm sure that your community is still reeling. So to Shelley and Lori and those of you who live in that community, we know this is not a one and done. This is going to last for months, and we hope everybody can recover. We hope that your community can recover, and we hope that there's no more loss of life that happens as a consequence of this disaster. So to all of you, thank you so much. To the folks who are on the call, who typically go over to Dr. Pepe's webinar, take a look at the link on the right-hand side. Everybody is welcome to join. Dr. Pepe runs a webinar, which is an international webinar with all the EMS folks from across the world. This is every week. You all are all welcome to keep joining us every Friday, 11 a.m. We've been doing it for years. And this talk will go up on YouTube by the end of the day. So to everybody, thank you. Stay safe. Thank you for joining us. And we'll see you next week.
Thank you.
Thank you.
Thanks,
Appreciate it.
everybody. Appreciate your time today. Thank you guys so much. It was amazing.